and welcome to our session, Disease Management, Caring for Your Kidney Kid in General and During COVID-19. I'm Jack Lennon, an AAKP Ambassador and current transplant recipient. As a lifelong kidney patient, having been born with post-urethral valves, I've experienced many elements of kidney care, including both hemo and peritoneal dialysis, as well as being a 3-time kidney transplant recipient. Due to the nature of PUV and the resulting kidney disease, I've grown up having to manage this condition. And as a result, I have a very special place in my heart for children struggling with kidney diseases and the challenges that they endure as they transition from childhood to adolescence and finally into adulthood, as they try to understand their condition and take more responsibility for their health care as they age. This has never been more difficult than now during these unprecedented times as we face the coronavirus pandemic. Professionally, I've been the executive director of the Improving Renal Outcomes Collaborative, or IROC, since 2019, a network-based learning health system of patients, their caregivers, clinicians, and researchers from over 40 pediatric kidney transplant programs from across the United States. The network works together to solve the most difficult problems for children with kidney disease. I'm involved with AAKP to connect with other individuals like myself with kidney disease and to improve care for us by increasing patient voice. Today's session is presented by the AAKP Pediatric Kidney Pals Initiative. Launched in 2017, AAKP understood that chronic illness of any kind in children is very difficult for the caregiver unit, parents, grandparents, aunts, uncles, siblings, and especially the child. This initiative is dedicated to supporting that caregiver and family unit as they navigate life with kidney disease. Without further ado, I'd like to welcome and introduce our session speaker, Dr. Jens Goebel. Dr. Goebel is a pediatric nephrologist at Helen DeVos Children's Hospital in Grand Rapids, Michigan. He's not only a good friend of mine, but of IROC, the organization I lead, and has been a great friend of AAKP over the years, having contributed to educational programs, articles on pediatric kidney disease. We're very honored to have him join us now as I turn it over to you, Dr. Goebel.
Hello, my name is Jens Goebel. I'm a children's kidney doctor. And I practice at Helen DeVos Children's Hospital in Grand Rapids, Michigan, where I'm the section head of the section of pediatric nephrology. My academic affiliation is with Michigan State University. It's an honor and a pleasure to be, I should say, re-involved with the AAKP, because many years ago I co-wrote a couple of articles in the AAKP's magazine about children and kidney and blood pressure issues and sports with kidney conditions. So it's great to be back, even though the circumstances are, of course, quite different. And my understanding is that one of our 2 topics today are the circumstances, namely what might be some pointers and some challenges to talk about that come with having children who have a kidney condition in the days and ages of COVID. The other topic today, which I'd like to start with, is a less current but ageless topic. And the name of that topic is transition. And transition means what needs to happen when children become teenagers and young adults, but continue to have whatever chronic kidney condition or urinary tract condition they may have, but become too old and too independent to continue to receive their care in a pediatric environment, and therefore need to transition into an adult care environment. Transition is one of our, as people who love taking care of children, one of our biggest challenges and to some extent fears. And we know similar challenges and fears are experienced by these children who are becoming adults, because they usually like the care they've been receiving by us for many years oftentimes, and so do their parents, who also are nervous about any kind of transition into the adult world. And last but not least, whoever is providing care in adult environments is a little nervous about our quote-unquote graduates showing up in their institutions and offices to continue their care, because they know that that former pediatric patients are potentially special, unique, and a little bit spoiled by us pediatric providers over the years. So there's nothing easy for any of the involved parties that comes with transition. Nonetheless, it needs to happen because we don't know enough in our pediatric background about adult conditions, and the care is no longer optimal for young adults if it would be continued to be provided by us. So transition in some form or fashion and at some point is unavoidable and necessary. There are some general rules about transition that are pretty broadly applicable, but there are also a lot of individual possible influencers of how that transition may look like for any given patient or any given family. Some of the general rules are that transition doesn't happen overnight. Transition is a process that moves forward over a number of years. In our pediatric behavioral and psychosocial literature that deals with transition, there are certain time points that begin in early teenage at the latest. So a number of years before somebody turns 18 or 21 or whatever, there are early time points in early teenage where patients with chronic conditions that are expected to stick with them into adulthood will begin to be assessed for what's called transition readiness. And there will be conversations that will happen every so often during clinic visits with us pediatric specialists about transition down the road and how to make that the least uncomfortable and the safest. Transition readiness can mean a lot of things and is sort of required to a large extent to be built up over time with, of course, our help, the help of our social workers, our staff. It just depends on what exactly is at hand. Things that are commonly used as examples for transition readiness are can a teenager call in his or her own prescription refills, or is that still being done by the parents or by somebody else in the family? Can a teenager call and schedule or reschedule clinic appointments? Can a teenager manage medications at home if they have a pill box and need to know which pills do I need to take in the morning, which pills do I need to take at night? So is there enough understanding of what these pills are there for and what to look for, but possibly regarding side effects, and what would happen if one of those prescriptions would run out accidentally? So these are all examples for what's sort of referred to under the umbrella of transition readiness, and that's a pretty general principle and a pretty general and broadly applicable component of transition. In more individual examples of transition, of course, have to do with several possible things. One is, where will any given patient transition to, and exactly when? It probably makes no sense to transition somebody who is beginning their senior year in high school and is planning to go to college on the other end of the country after that. It might be better to provide that continuity of still pediatric care during that senior year in high school, and then help find a place to transition to that is close to where that person is planning to spend the next 4 years in college. So transition doesn't have to happen the night somebody turns 18 most of the time. Most pediatric programs have a fudge factor regarding age up to which patients can continue to come and see them. So you can be flexible and individualized in how you actually set up the timing of the transition process. Transition also is individualized, and this is of special interest for some of the families and patients that are involved and represented by the AAKP. It's also individualized about what type of subspecialty care is available where in the adult world. One prime example in our patient population are children whose kidney condition also involves the lower urinary tract, oftentimes via congenital malformations that we see pretty often in our pediatric nephrology populations, but that we co-manage with our pediatric urologists. But those conditions are, relatively speaking, much less common in the adult urology environment, for example, and the adult nephrology environment. So it behooves a transition process to keep these things in mind and really explore and eventually find the right providers with the right knowledge and the right interest for these predominantly originally pediatric conditions that can, in this case, affect the kidneys and the urinary tract. So that's a component of transition that needs to be highly individualized. And then a couple of other aspects, perhaps to wrap things up. Obviously, not every patient, including not every child, becomes a completely functional adult the day he or she turns 18. And more complex, as an example, are children who have cognitive impairments, neurodevelopmental delays as part of their disease that may also affect their kidneys and their urinary tract. And you can't obviously say to these children, oh, now you're 18, your parents can no longer help take care of you, and you're on your own, you need to go into the adult world. So obviously, that support for those patients who need special support by family, by loved ones, by friends, because of, for example, neurocognitive challenges, that support needs to continue in the adult world. And if we go to our doctor's office for visits, then we know that not every adult patient can handle whatever challenges they're up against without some support, because adults have some cognitive challenges sometimes as well. So that model is not unheard of in the adult world. And then lastly, there are a fair amount of publications out there in the pediatric literature, medical literature, not just in kidney and urinary tract disease, as to how exactly best to do transition. And many centers, our own center included, actually, in addition to regular transition preparations over the years leading up to the actual time of transition, in addition to these transition readiness assessments during clinic visits in our pediatric environment, there are many centers who have something that might be called a transition day, once or twice a year, or a transition boot camp, where families and patients meet some of the adult providers, not just doctors, but also nurses, coordinators, social workers, pharmacists, and have basically a whole day of conversations and, for the lack of a better word, classes about how the adult care environment works and what's different about it compared to the pediatric environment. And if the if whatever adult environment may look like a good example for a target for transition for those patients and families as needed to be seen going forward, if that institution or that facility is close enough to the pediatric center, one can even sometimes find programs that actually arrange tours of the adult kidney clinic or the adult urology office. So in a protected way and as a group with some guidance, families and patients see the eventually new environment that they will begin to receive their adult care for. So that's one pretty standard and valuable component of this whole transition process that many programs try to facilitate and set up. So with that, I think we can, no pun intended, transition to the other topic, our more acute topic, which is what do I do with my child who has kidney and urinary tract disease in the days and ages of COVID? And there are a number of different answers to that. And they can be simple and they can be complex. One simple answer as well, you should follow the guidelines. The complexity of that answer comes with, well, whose guidelines? Do I follow the CDC? Do I follow the FDA? Do I follow Dr. Fauci? Do I follow my local school district? Do I follow the rules that the governor in my state is making about mask requirements, et cetera, et cetera? So many potentially confusing resources that are all well intended, but can sometimes even come up with different and opposing recommendations and suggestions. But somehow it's helpful for everybody, not just for children, and certainly not just for children with kidney and urinary tract disease, to be aware of those guidelines and try to follow them as much as possible in whatever seems to be the most reasonable way going forward. Generally, I'll just say it both as a person and as a medical provider, I feel pretty strongly that if you're able to get vaccinated, you should get vaccinated. I know that the vaccines currently are not approved for children under 12, which introduces a whole nother headache and a whole nother source of fear and confusion, because now many places are trying to send kids back to school, and there's concern that obviously the schools can be sites of virus transmission, and that is still a challenge that is not completely resolved, and probably won't be resolved until A, much younger children can also be vaccinated, and until B, there's enough willingness amongst parents and families to get their children and themselves vaccinated. I always like to remind everybody these vaccines are, first of all, safe and effective. And they don't just protect whoever gets the vaccine, they also protect whoever that person interacts with, be it at school, be it at work for an adult, be it at home with his or her loved ones in the family. So not getting these vaccines, unless there's a true reason, medical reason mostly, to not get them, which is very rare, is basically a little bit like deciding to run a red light or a stop sign. So getting vaccinated is obviously something everybody who's eligible should strongly consider. As far as children with kidney and urinary tract disease is concerned, there really is no dose adjustment in the vaccine or whatever if for somebody who has decreased kidney function. Thankfully, that's not a problem or a necessity. It becomes a little more hairy in those children with kidney diseases that require immunosuppression. For example, our kidney transplant recipients, and but also a number of children who we treat with immunosuppression for diseases like lupus or certain types of nephrotic syndrome. So a number of patients who are not transplant recipients but are still receiving immunosuppressive therapy to help manage their underlying kidney disease. The the impact of immunosuppression, of having to take steroids or whatever immunosuppressive medicine or medicines are required, on the immune system's ability to respond to the vaccine is difficult to specifically determine, but it is clear that immunosuppressed people have less of a response in all likelihood to these vaccines than people who are not on immunosuppressive therapy. And that's one of the reasons why recent recommendations now suggest that transplant recipients who have received a two-dose series of COVID vaccine should definitely receive a third booster dose to enhance this somewhat suboptimal immune response to the vaccine that is interfered with or caused by the immunosuppressive therapy that is being used. So that's how some of our children are affected by their medications that they need to take in terms of how much they may benefit from being vaccinated, but that shouldn't discourage folks from not getting the vaccine at all. The other question that comes up a fair amount is what about antibody levels? So these vaccines all work to induce an antibody response, so induce our immune system when and after we get these vaccines to make antibodies, which are protective immune proteins in our body, to make antibodies against in this case, the COVID virus. And we're still on a learning curve how to assess and interpret these antibodies. One, there is no super clear consensus how high somebody's antititers need to become after the vaccine to be 100% protected versus to be suboptimally protected and maybe need another dose. There are studies ongoing that are looking at all of this, but there's still some uncertainty. The other uncertainty about these antibodies against COVID, whether these antibodies have developed as a consequence of COVID vaccination or as COVID infection in and of itself without any vaccination in the mix. The other uncertainty is it is unclear how long these antibodies remain detectable and usable in any individual who got vaccinated and or who had the actual COVID infection, because these antibody titers can decrease over time, and therefore any kind of protection can decrease over time as well, which is where this whole discussion is coming from, that is now evolving about shouldn't everybody get a yearly booster as well of the COVID vaccine, because these antibody responses need to be re-triggered, re-enhanced, and then that looks a lot like our yearly flu shot has looked historically. So still a lot of uncertainty, still a lot of information to find out, but the data regarding safety and efficacy are pretty convincing, as unfortunately are the data now, where in the current surge, basically 95% of people who end up in the hospital with COVID or dying with COVID are unvaccinated. So pretty compelling information from a medical perspective. I think there is a lot for families, kidney disease or not, that goes beyond what we just talked about as far as following guidelines, social distancing, wearing masks, whatever those guidelines and recommendations are, and getting the vaccine. The whole concept of, do I really need to take my child for his medical appointment or her medical appointment, that we need to usually keep twice a year, because my child has some kind of kidney problem. And so on our end, what we've really learned to use and can offer a lot more now, thanks to COVID, is telemedicine. So we do a lot of virtual visits over the internet, securely, of course, with some of our families. And I think a lot of that is going to stay, because it's just also more convenient, because we oftentimes see kids from several hours away from our center. So that's still a learning curve, how to meet whatever medical follow-up need is concerned, under the threat of COVID. And we're in the process of refining how we approach that, and every family is different. Some families say, no way, Jose, do I go to a medical facility for some routine clinic visit for kidney disease in my child. Other families are the exact opposite. They say, no, my child needs to be seen, and my child needs to have his or her blood drawn, just like we've done in the last so many years. So families and teams need to figure out how to deal with those kinds of concern, in this case, children with kidney disease or urinary tract disease, in a pretty individualized way. And usually things can be made work one way or another, but as I said, it's pretty individualized. And then, I would also say, the medical staff, nurses, providers, the whole system is pretty worn out from these 1.5 or whatever, almost 1.5, I guess, years of COVID. There has been a lot of hard work. There has been some COVID infection, affecting and incapacitating a medical staff. So if you are in touch as a parent with your child's kidney or urology care team, you may not always encounter the most relaxed group of providers and team members, because of what COVID has done to us as a group of medical professionals and care providers. So many additional aspects and challenges, and some positive learning opportunities, for example, virtual visits, telemedicine, but also, like I said, many challenges. I think I'll close there, and I'm sure the AAKP and Jack, our moderator, are willing and able to share my contact information. And if anybody needs to reach out and get some additional questions answered, elaborate on something a little bit more, maybe point it to some resources. So many medical entities, whether it's the AAKP, whether it's the American Academy of Pediatrics, whether it's the American Society of Pediatric Nephrology, the American Society of Transplantation. A lot of medical entities have come up with all kinds of pretty good information materials about COVID in pediatrics, and sometimes it's just a matter of being pointed in the right direction to find additional answers to all these questions. But for now, I think I should stop here. I want to thank Jack and the AAKP for having me, and it was an honor and a pleasure to do this. Thank you very much.
Thank you, Dr. Goebel, for an important and informative presentation. We really appreciate you sharing your time and expertise with us. If you'd like to learn more about AAKP's Pediatric PALS initiative, please visit bit.ly/AAKP Pediatric Kidney PALS, all one word. And if you'd like to learn more about IROC, please visit irocnow.org or irocnow.org. Thank you so much.